Thank you. If you are the leader, press star now. You will now be placed into conference. To mute your line, press star 6. To unmute, press pound 6. To have our expert speakers today, and we'll be starting that in just a moment. I just wanted to go over a few things that are in the room here. You'll see that on the left-hand side, there is a box called Files, Files 4, and in that box, you'll see Alternatives to Opioids. So that is the presentation, the slides for today, and if you'd like to download them, you highlight that Alternatives to Opioids and then click Download Files. I also wanted to tell you about the web links that are on the bottom left-hand corner of the room. So we may be referring to a website called Pain is Personal today, so that is a link to that page, and you just highlight that and then click Browse To, so that'll bring you there. So if you have any, we also want to encourage you to type your questions into the Q&A box so that we can present those questions to our presenter today, who can respond to your questions. And feel free to chat in the chat box below. So we will, this presentation will last 1 hour, and there will be a feedback survey at the end. So I'd like to now turn it over to Dr. Harry Kovelman. He's the Executive Director of Medical Affairs for Pacira Pharmaceuticals. Welcome, Dr. Kovelman.
Well, thank you, and welcome all our participants to our webinar today. It is my pleasure to introduce Dr. Mike Kelly. Dr. Kelly is the Chief of Orthopedics at Hackensack University Medical Center. He's also the Director of the Insel Scott Kelly Center of Orthopedics. He's a Professor of Orthopedic Surgery at Rutgers Medical School. Mike has authored numerous publications in a multitude of orthopedic topics over the years. And most importantly, over the past several years, Mike has been responsible for heightening the awareness of the risk of dependency on opioids after a surgical procedure, and really now leads the discussion on the implementation of an opioid-sparing multimodal post-surgical pain management strategy. A little housekeeping before I turn it over to Mike. Please feel free to type in your questions during the presentation, but as said before, for housekeeping sake, we will hold the questions till the end of the presentation. So without further ado, I pass it to you, Dr. Kelly.
Thank you, Harry, and it's an absolute honor to be here at Faces and Voices here in Washington, D.C. I actually went to high school about 6 blocks from here, but have a great deal of respect for what many of you in the audience, as well as what they're doing here as we fight this battle together. As Harry has told you, I was introduced to some of these issues about 3 years ago, and it amazes me almost every day of the fight that we have on our hands here. I'm going to, over the next 40 minutes, share with you some of the issues related to the opioid epidemic, and then we're going to talk a little bit of how we at Hackensack and elsewhere in this country have begun to use what's known as multimodal techniques for pain management to minimize the use of opioids. We must manage the pain. We can't just get rid of the medicine. So we have to figure that out together. And as we started here on my disclosures, you should know that I do have a relationship with Pacira. So if you look here on this map, the abuse of opioids has a devastating impact on the public health and safety in this country. The amazing thing about this map is you see the little yellow dots. Well, those are 12 states that had more opioid prescriptions than human beings in the state. And so that as we look on, you can get an idea of the impact here. I'm told that 1 in 6 adults in eastern Tennessee are opioid dependent. So it's a significant problem. It's not just our children, but all throughout all age groups. We're going to talk a little bit about the first lifetime exposure to opioids, which can be critical as things can get a little bit shaky later on in some people, and the diversion or the leftover opioids that are an amazing issue in this country that we're first realizing and coming to grips with. So how do we get here? 70 million patients per year are prescribed opioids for post-surgical pain. And as we look, and probably well aware, many of you, 1 in 15 will go on to long-term use or abuse. And some of this comes from people like me, who prescribe opioids to manage pain after a knee surgery, which has been my career for the last 31 years. And on occasion, some of these people move along to addiction. Excuse me. If we look at the use of opioids in perioperative pain management, so it's not a surprise to anybody in the audience that 98% of patients, this is in 2009, receive post-surgical opioids for their pain. When we started this in the early 90s, when we began to get OxyContin and the other type of addictive opioids, we thought they were the answer to all our problems. When I do a total knee replacement, it's extremely painful. And early on, we would have an injection where for 2 hours the patient would be halfway asleep, but in no pain, and for 2 hours would be howling and asking what time is it for the next injection. Now we have different ways to administer them, but the adverse events are still there. Opioids are a highly effective analgesia, but evidence suggests they may not be the perfect one for pain that I'm dealing out in the knee or extremities recovering from surgeries, not just orthopedic, but all types. So we're going to talk a little bit of how we began to tackle this opioid problem, and we're hoping to continue to carry this message on until we have a better handle on it. We're going to look at preventing the adverse drug events that go along with this. I'm going to explain to you what multimodal care is and give you a little taste of what we're doing utilizing these techniques, and to talk about trying to reduce the misuse, abuse, and diversion associated with these medications. So if we look at opioid adverse events, they are definitely there. We see them particularly when we were using what's called patient-controlled analgesia, or the ability of a patient to manage their own opioid use using IV opioids at the bedside. Incidents of common opioid-related events include itching, which can be severe, urinary retention. Post-op nausea and vomiting has been a very difficult one as we try to mobilize our patients. Roughly 1/3 get dizzy. They get what's called hypostatic in their blood pressure, hypotension, where as they stand, they feel like they're going to faint. And it makes it very difficult to go along with their physical therapy. Central nervous system effects. And in here, I would throw a couple other things. Any of you who have watched the Super Bowl have heard about opioid-induced constipation. These are the most expensive ads that we have in the United States of America. And when you see an advertisement like that, you think we got a problem? Absolutely we do. And opioids are the leading cause of pharmaceutical overdose mortality. So if we look at the burden, it's not just to the patient, but to society in general. You can see on these slides that there's a cost-related issue. There's an increase in length of stay related to these adverse events. In this day and age, most times a knee replacement may stay 2 days. Oftentimes when they have these types of problems, it can almost double that to 4. And here you can see readmission rates, which are highly costly and difficult for the patient, highly costly to the medical center, and now particularly as Medicare is trying to manage these readmission rates over the first 90 days of post-op care, these are very significant problems. So let's look at a couple of these issues as we turn to the literature. One of the take-home messages today is the initiation of short-term opioid therapy in the acute setting may lead to long-term use, and this is where I come in. There's a high potential for misuse, dependency, or diversion, or the use of the medication existing in all our bathrooms today, and it starts potentially in the acute setting, either managing fractures or post-operative treatment. If we turn to the cervical spine study shown on your slide, spines are very painful. Nerve pain is very difficult, and many of these patients are impacted by opioids. If we look at a study of cervical spine surgery, and we look over a 1-year period of time, approximately 1/3 of all patients in this particular study were still using opioids. Not surprisingly, 18% of patients who did not use opioids before surgery were still using them at 1 year. So that's 18% new chronic users. There were some chronic users beforehand, as there aren't any spine series, but that's very, very difficult to understand. Now we look at the idea of diversion. Many, many times on a Monday morning I have a young man who comes in to see me, who injured himself playing softball, a weekend warrior like myself, and I say, did you take a little Advil? Did you take some Tylenol? He said, no, my wife was in oral surgery last week, and she was given 40 opioids, and I wolfed down a couple over the weekend and managed to make it here till Monday morning. We hear it all the time, and I'm sure you do as well. So if we look here at an upper extremity surgical procedure, all these patients received post-operative analgesic prescriptions for 30 tablets of opioids. And they were asked to call in at 6 weeks and to report how many of the pills they had utilized. Roughly 2/3 of these pills in each patient were still in the family coffers, in the bathroom or wherever they keep them. Almost 5,000 leftover opioid pills in this small study. Just extrapolate that across the country, and that's what we're seeing. Addiction after surgery does occur. We hear it all the time. I've got several people in my town who I coached. One was a young lady, first and second grade softball, age 21, at 19 had a surgical procedure in orthopedics and went on to be an opioid dependent and die of a heroin overdose. This is seen all over the state of New Jersey in all asset classes. There's no freedom from this in our state, and I'm sure around the country. So we see the patient, his or her clinical or social history or environment certainly has an impact on this. Over-reliance on a drug with known risks, as I talked about, these patient-controlled analgesia, certainly it solves the pain problem, but the adverse events and the potential for a very significant addiction problem later is something we can't continue to tolerate. The combination of these factors can and does lead to opioid abuse and addiction in patients undergoing elective surgery in this country. One of the most difficult slides for me is this. If we look at the bottom part of your slide to begin with, I coach a lot of youngsters. My kids are only 22 and 24, but the odds of medical misuse of opioids due to taking too much following a standard prescription for either an orthopedic injury or a dental procedure is 10 times higher than those who have not been given a prescription of opioids. And as I said, it's not just our kids. Here you can see in patients greater than the age of 65 years of age undergoing low-risk surgery who received an opioid prescription within a week of surgery, and this is an amazing figure, over the age of 65, 10% were still taking opioids a year later. There was a 44% increase that they would become long-term opioid users. Again, exposure in the acute setting can lead to long-term opioid use, and that's what we're hoping to avoid with this multimodal. There is collateral damage here. Here you can see a graph looking at neonates who were born to addicted mothers. And over almost an 8-year period, you can see almost a doubling of both the cost and the number of maternal hospital stays related to opioid use. It's very sad to see the issues related to these youngsters that are born into this country with a problem that they certainly don't deserve. We've actually been working in our obstetrics clinic at Hackensack and have minimized the use post-cesarean section to opioids dramatically by using multimodal as well. We may have started in orthopedics, but we're spreading out around the hospital. Now let's look at a couple of at-risk populations. Patients with comorbidities, and this is a big deal in what I do in knee replacement. Both obesity and addiction share in common the inability to restrain behavior despite the awareness of its negative effects. Reduced concentration of dopamine receptors may be the anatomic feature that contributes to this. In patients, thereby, that same population undergoing bariatric surgery or surgery to minimize and enhance weight loss by doing some surgery in the area of the stomach are oftentimes susceptible to addiction. And here you can see some of those studies. In a recent study, almost 12,000 bariatric patients, 56% of patients had no opioid use, 36% had some, 8% had chronic opioid use. 77% continued chronic opioid use in those patients with chronic use after their surgery. So losing weight did not stop their problem. And let's look at our veterans. Sometimes a lost cause in this country, and that's very sad. Chronic opioid use among veterans is increasing. The prevalence of diagnosed opioid abuse is almost 7 times higher in this population than those covered by commercial health care payers. Prescription opioids are associated with an increased risk of adverse events, as we've talked about, resulting in frequent emergency room visits or inpatient admissions. And this is aggravated not just with post-traumatic stress disorder, which is very high in these people, but virtually any mental health disorder. Beyond chronic opioid use, veterans with post-traumatic stress disorder may be even a higher risk for addiction. And the combination of the war trauma and trying to reacclimate into this country increases the risk of both prescription opioid abuse and then possibility of addiction on top of that. So this is a very high-risk population. When we look at some of the issues related to the cost of this, virtually every state in the union and the union itself are struggling with this, as you'll see as we complete this talk with some of those numbers that we've had, both at the national and state level. Here you can see on your left, and I draw you not necessarily to the specific numbers, but the overall hospitalization rate of people related to opioid abuse or misuse. And if you look at the slope of that curve over a 10-year, a decade period of time, from 02 to 12, it's nothing but going from the lower left to the upper right. It's a problem that continues today, and we're really trying to get a hold on this. And as I said, there's no age group above the age of 18 that is not involved in this, and it varies. Here again, over that decade, different age groups were related to higher issues related to hospitalizations, to opioid misuse. For me, problematically, as we look, the highest and fastest growing age population of joint replacement is in the 45 to 55, 60 years old, and they were at the top of this list when this was published. Problematic and something to be aware of. One of the things we really need to talk about is diversion of pain relievers, and it's very, very common. I actually didn't know what this word meant until I began to giving some of these lectures. So the use of the pain pills that, when prescribed, come home with the patient and are then not used. So 68% of people using pain relievers non-medically obtain them from a friend or relative. There was a bit of a pie chart here showing you exactly how those percentages weighed out, and I can assure you the drug dealers were in the very, very smallest percentage of people involved in where these friends or relatives were giving these people the pills. These weren't coming from people selling drugs. It was coming from our own friends and relatives. According to this 2012 survey, 20% of teenagers claimed that they could get a prescription drug to get high in less than 1 hour. They actually could almost get this just as easily as they could go get someone to buy a beer for them. So there has been some government responses here, and recently President Obama got involved. You know, as physicians, we received a letter from the Surgeon General just this past summer relating to the opioid crisis. And while I admire that letter and that effort, it's about 3 or 4 years too late. So at least we're getting on top of it now, but this has been brewing for quite some time. And here we can see the Comprehensive Addiction and Recovery Act of 2016, signed into law by President Obama this past summer. And it's looking at the prescription opioid drug abuse and addiction here. So they began authorizing grant programs for abuse prevention and education, including prescription monitoring. So say in the state of New Jersey, we're surrounded by New York, Delaware, and Pennsylvania. And it's taken us we were actually involved with drug monitoring, meaning that when I write a prescription for an opioid, I can go onto this site. In our case, we had already established this in the state of New Jersey, and we commingled with New York, Pennsylvania, and Delaware, just recently New York. So I can see if that patient has had a prescription of opioids filled in whatever the time zone is, wherever that pharmacy is. And so many of these people who get addicted begin a doctor shopping episode where they go in feigning illness, feigning pain, feigning injuries, trying to get another doctor than the one who had written the previous prescription to write them yet another. He also expanded access to treatment and recovery options, which I really encourage, including medication-assisted treatment and overdose reversal drugs. We have a big problem with this in my state, and many of our psychiatrists don't accept insurance, and I've had several of my own daughter's friends on my couch in my office with issues related to this, scared to talk to their parents, and really having nowhere to go. And so this is a tremendous thing, and I really applaud this. We're expanding law enforcement grants and prescriptions for drug take-back medication programs. And this is actually a law in the state of New Jersey where those people who are writing the prescriptions for opioids must also counsel their patients now on how they can get rid of these medications when they are done with them. If there are leftover medications in our area, we go to the local police stations where we can turn them into a lockbox. But this is a very important thing because just recently in an article of Scientific America, it was entitled that opioids are addictive, but the prescriptions are not. And many people in this, quoted in this article, believe that diversion is one of the leading reasons that lead to addiction. And they're providing specific opioid abuse prevention, treatment, and recovery resources to veterans, women, and children. And in here as well, in my little town, we've had 30 overdoses in the last 2 years, all saved by the use of Narcan, in most instances by the police. So that is a real turn of events, and I think very beneficial. So if we look at the government response to opioid crises, you may be more aware of this than I. The FDA is mandating significant changes. A black box warning has been added for all immediate release opioid medications, and a comprehensive reassessment of the regulations surrounding opioid prescribing is underway. And this has gone very significantly to the state governments. And it'd be interesting if we have any questions on this in the post time here, because I'm not sure that this is perfect. As you know, pain needs to be managed. There is a place for opioids here, not exactly sure where, but in many of these states, the restrictions are getting very restrictive in the amount of opioids that can be prescribed, both in the emergency room and from the doctor's office following surgery. And here you can see just a couple, Massachusetts and Kentucky. Again, numerous organizations are supporting the use of opioid-sparing multimodal post-surgical pain management, which we're going to discuss now. And here you can see they're representative across the whole spectrum of medicine. Interestingly, the American Dental Association, and recently we were talking with the oral surgeons at a meeting just recently. In Colorado, where we held a meeting, 30% of these opioid prescriptions are written by dentists and oral surgeons. So everybody's involved when there is pain to be managed, and we all need to get on board in trying to prevent abuse. Now we're going to talk a little bit about multimodal, and I will try to make this easy to understand. This is a picture of where the stimulus of pain is initiated. In my case, it would be in the knee, could be anywhere where surgery is pronounced or a fracture is taken. It then transforms through the spinal cord and then up centrally into the brain, as you can see here. And so the simple definition of multimodal pain management is the simultaneous use of a combination of greater than 2 analgesics that act at different sites within the central and peripheral nervous system in an effort to reduce pain, minimize opioid use, and thereby minimizing opioid-related adverse events, minimize the side effects of any individual therapy, as all these medications have some side effects, but get good pain management. And you can see in the green various treatment options that I'm going to talk about here will impact this pain pathway, if you will, at different locations. Some centrally in the brain, some in the spinal cord, and some at the location of the stimulus, wherever the surgery or injury may have taken place. It's a fairly straightforward understanding, and what you can see here depicted in these pyramids is the conventional treatment, which was conventional until not very long ago. maybe several years. Orthopedics has been pretty good. We've been looking at multimodal now for 8 or 9 years. But just in general, I think the pyramid on your left is still used by some, unfortunately, which is you start with the weaker opioids, you then go to the more potent opioids if they're not effective, and then when you have breakthrough pain, you give even more opioids, or perhaps you can use things like an epidural catheter. Epidural catheter is thought of like a spinal anesthetic, but the catheter remains in place, and you can give medication through the catheter to impact the spinal portion of that diagram I showed you just in the last slide. So we've changed that quite a bit now, and you can look at the mild to moderate pain. We use acetaminophen. People sometimes say, oh, that's just Tylenol. Well, it's a very, very effective drug, whether used orally or intravenously. Non-steroidal anti-inflammatories, so many of you use these on a weekend basis, like Advil and Aleve, things like that. Some of the anti-inflammatories can even be more specific in their therapy, and they're called COX-2 inhibitors, and in this case, we use Celebrex. And then there's medicine that you sometimes seen advertised in your papers and on the TV, something like Lyrica, which is used for diabetic neuropathy, or basically a nerve type of chronic pain can also be effective in helping us manage these people, as well as a revitalization of local anesthetics, which we'll talk about in a few slides. Most of the time, this works quite well. Oftentimes, we may have a little bit of breakthrough pain, so we'll go to the top of the pyramid here. We call that rescue, and we still use some moderately dosed opioids orally there. In the moderate or severe pain, one can then use neural blockades or peripheral nerve blocks, and then medicines that many of you may not know about, but medicines such as ketamine, which can be a pain reliever as well, often is used by anesthesiologists as well as pain management people. So we may be getting it in our treatment, just not knowing it. So some of the agents we use in multimodal analgesia, as you can see here, there's many of them. And we're not going to go into each of them together. But some of the ones that we have found very effective include the ones I've just spoken to you about. Using something from the category of nerve pain, neuropathy-type pain medicines, and gabapentin or pregabalin. We will always use an anti-inflammatory agent unless allergies or issues related to adverse events with these, such as stomach disorders or ulcers or history of GI bleeding, blocks us. There are times when we can't use these. Acetaminophen, again, unless you have a liver problem, this is a standard for us, and we use it both orally and intravenously. And sometimes cost of medication is impacted in these particular selections. There are some other medicines, as you can see here, that are used from time to time as well. And we can come over to the opposite side, and I draw your attention to the local anesthetics that we're going to talk about. Orthopedics has used these in a very significant fashion, particularly in the knee and the hip, others as well, spine. And you can use them in a variety of ways. And you can see here that some of that are you're used to, you see from your dental work. But many of those are shortened by the length of time that it takes to get rid of the medication, which is known as the half-life. And others have techniques that will allow you almost up to 2 to 3 days of relief by the manner of delivery. And so there's a lot of things going on in this space as well. Again, when we look at the incorporation of locally acting anesthetics into multimodal approach, I think it's almost uniform, or certainly used in many, many places around the country. It's utilized during many surgical procedures to target the pain at the source. So where the stimulation of pain is occurring, where that is, maybe in oral surgery in the oral cavity, in my world in the knee cavity, but they can be used in a variety of places throughout the body. Single dose administration, as I talked about, is limited by the duration of traditional local anesthetics. And many of you have been to the dentist where you receive a nerve block, that you leave the dental chair and you're still numb for many hours later, usually 3, 4, 5, usually max of about 6, and then it begins to wear off. Efficacy and administration technique are procedural and patient-specific. And so some of these medications, liposomal bupivacaine in particular, is one by the delivery mechanism can go out to 2 or 3 days. So one of the issues here that we feel is important, and you're beginning to see it. We've been in these discussions about 3 years ago, and virtually nothing was in the media. Maybe every once in a while there'd be as the addiction became fatal, you would see that written in your paper. In my paper, there was a whole front page up in both sides of the folder of pictures of patients or people in my own county in New Jersey who had passed due to heroin and opioid addiction. But now we're seeing it quite a bit, and the patients are beginning to come in and talk about it. And they're working with us, I think, when we say, well, let's see if we can't get by with Advil or Aleve or Tylenol, and we'll see if we need breakthrough pain medication, then maybe the opioids are the way to go there. My own daughter just broke her collarbone, and we started with Advil. She's taking that around the clock and is utilizing a small dose of opioids when it gets to be that medication needs to rescue her. Individually tailored education to the patient and or responsible caregiver, including information on treatment options for management of post-op pain and documenting the plan and the goals of this post-operative pain management, I think is critical. The American Pain Society published these guidelines, which are somewhat general in nature, and each particular doctor and or in our case, our program, has a specific pain management plan that is similar for all patients who undergo joint replacement. They may be utilized a little bit differently with respect to rescue, but they are all similar. And so this helps quite a bit to train our patients, to train our nurses, and to manage our patients. We occasionally have patients who've been on opioids for some time preoperatively, and these are the most difficult for us to manage their pain without opioids. These are given a referral to our pain management crew, and in that case, these people also, ironically, are hyperesthetic, and they will experience more pain following such a procedure if they've been on these medications for a lengthy period of time preoperatively. So those patients are managed now on an individual basis, where many times they flew below the radar in the past. Education to all patients, adults and children alike, and primary caregivers on pain treatment plans are very, very important, including the tapering of analgesics after the hospital discharge. As I look back on my own performance over these years in managing pain, there's a clear recollection of patients who come to me at 3 months saying, you know, doc, those medicines work pretty good for the pain, but boy, was it hard to get off them. And that's because they basically were becoming opioid dependent, and we did not discuss that with them, and we probably should, and spent more time on this tapering issue. So there is hope, and here's a place where people can get, and prospective patients and their loved ones. We insist when our patients come in that they have a coach with them, meaning a loved one or someone who's going to share this experience with them in some respects and help them understand all the material that is coming at them. We see that the educated patient has a much better experience, that their clinical success is much better, and we can meet their expectations. And this is an area where you can learn about this in a website, Plan Against Pain. Choices matter in pain management. And so you can be part of this process, and you should be part of this process. As you can speak with your doctor, you can educate yourself, you can have the people in your life who care about you and are going to be involved in whatever the process that may initiate the pain, maybe surgery or something. They can help you. Let me get this, sorry. And so here you can see there's an interactive website here, and it provides access to information and downloadable tools to facilitate patient and clinician discussions. And here you can see some of the questions shown on your screen that will help you try to get an idea of what's going to go on and how you can help manage it by discussing it with your surgeon. So I would encourage many of you in this business to perhaps visit this website and see the attempt here at helping patients manage their pain in these particular difficult situations. In some cases, oral surgery, trauma, orthopedics, whatever the cause of pain may be. Well, I apologize. I'm having a little trouble moving this slide forward, but we're coming a bit towards the close of this procedure, of this lecture, and we're going to just review a little bit of what we have learned here. There's clearly an opioid epidemic. That's quite, I suspect, very visible to many of you who are on the line today, and is recognized by national organizations, state governments, and my comment here would be better late than never. Clearly, this has been going on a while. I showed you many papers that were written in the late 2009, 10, 11, and more data that's coming up now in 2015 and 2016. We're making an impact, but we have a lot of work still to do. And it's not just the patient's problem. As I showed you, if we look at the expenses that are generated by this, with the adverse events, the returns to the emergency room, readmissions, these are all very costly to all of us. And so hospitals, physicians, insurers, businesses, and employees are all involved in this. Communities, I recently was involved in my own little town where we had a town hall because of the number of opioid overdoses we had had and heroin overdoses, and a large number of people turning out, both at the doctor level and at the local population as well. So the message is getting there, and I think families are involved as well. My own daughter went to see one of my partners for her clavicle fracture or her collarbone fracture, and she came home with a recommendation to continue her Aleve. 3 years ago, he would have given her 40 opioid pills and said, come back and see me in about 3 weeks, we'll take another x-ray. People are starting to get the message. But we can't forget about the pain, and some of these patients do require opioids in a way that is very well supervised and educated. Choices Matter is a patient-driven campaign that I just shared with you. It raises awareness about non-opioid pain management options. It encourages patients to play a proactive role in their pain management after surgery, and I would encourage you to visit the website. Thank you very much.
So I think we're going to give Dr. Kelly a minute to catch his breath. Dr. Kelly, thank you so much for that presentation. And there's been a nice, steady asking of some questions from the audience. But before I give it back to Dr. Kelly, I just want to mention a couple of things as a result of some of the questions that are coming in. So number one, for everybody out there, I'd like you to know that Saturday, October 22nd is Take Back Day, where you can go on to www.deadiversion.usdoj.gov to learn more about locations in your area to drop off the opioids or narcotics. These are all up and available on the website. Some states are further along in doing this than others, just like some states are further along in the PDMP monitoring program. So I suggest the best way to know what's going on in your state is to visit the website, and it will make you aware of where you can drop off these meds, where the drop boxes are, where do they go, what happens to them. You can find out all this information on the site. So Dr. Kelly, are you ready to take a couple questions from the audience?
All set.
Okay.
Looking forward to it.
So number one, so the question from Beverly is, doesn't all pain start in the brain? And if it does, should we be focused more on, centrally acting, different choices, or should we keep with the multimodal regimen?
So I don't think all pain starts in the brain. We may feel it in the brain, but I think it actually starts at the site of stimulus. And so when I didn't get a chance to look at this with you in the multimodal way, but we can also break down this this program into what's called preemptive medicine. Okay, so we begin our medication prior to the insult of surgery. And so this is called preemptive, and we use an anti-inflammatory medicine. We use Tylenol, either IV or PO, and we use the neurologic medicine, gabapentin. There are some people in the country who do use one dose of oral opioids here, but it's been shown that if you have some of this on board prior to the insult of the or stimulus of pain, that you get better pain relief. Then we have the intraoperative one, and this is, we have very good data that things such as local anesthetics, right? So there you're not blocking the brain, you're blocking the stimulus, and they work very, very well to help us. And then there are certainly things known as blocks or peripheral impedance of the nerve that will cause the pain going from the knee to the brain, and these work quite well as well. And then spinal anesthetics and or epidurals that we've used for years where the brain is working well, but you are numb from the waist down. So certainly the issues centrally are important, but I think that the entire pathway contributes and is a, I kind of talk to my patients and say if there's 5 ways to get from my office to the George Washington Bridge in New Jersey going into New York, in the old days we would just block the most popular one, and all the other ones were not paid attention to. Now we use less medication and have the blocking for a shorter period of time, but all 5 pathways to the bridge are impeded. And so we hope that way we minimize adverse events but still get adequate pain relief.
So thanks, Dr. Kelly. We have another question coming in, and maybe delve into here the questions centered around drug screening, but also maybe as you and I do go around the United States and do these multimodal opioid-sparing meetings, we learned recently about human genomic testing. So maybe you can intertwine that here with this question. And the question is from Eve Klein, and it goes as this: is there evidence suggesting that preoperative urine drug screening is helpful for developing a patient-centered pain management plan? In other fields, there are current recommendations to screen all patients prior to starting opiate therapy for acute or chronic pain. Should we be thinking about this as part of our pre-op assessment, which also maybe you want to chat here about the human genomics and what they're doing with that?
So Eve, this is a tremendous question, and I know I can tell you that in our pain management clinic, all these involve urinary tox screens. And if you get a prescription for an opioid from our pain management group and you lose it, you're required to go to the police and file like a missing persons report almost before they'll give you another one. But just recently, Harry's referring to, we are getting ready to begin at Hackensack. I can't give you a time. I'm still fighting for resources. But I've been made aware of the ability to do genetic testing for all of these drugs. I think many of you are aware that the psychiatrists have done this for the antidepressants. Somebody in my family is utilizing them, and I was first made aware of this in the past year when I received the copay bill, and they utilize this. And what we know is so not just the substance abuse, we know that a certain percentage, maybe up to 30% of people getting opioid management can't metabolize it. And so then what happens? They get the adverse events through the secondary pathways metabolically, and what do? They probably give them more opioids. And so they get sicker and don't get pain relief. We're beginning to look at this, and your point is well taken. We've never done urine tox screens. If someone has a history of substance abuse or problems like that, these are patients that are very difficult to manage after surgery, and they're referred to our pain people. And so that plan is managed through them uniformly. We don't want 16 different surgeons managing these people. But now we have the ability to do genetic testing, and you can look at a whole host of different pain management ideas and drugs. And doing the genetic testing for multiple genes, you can now find out who is able to metabolize these drugs in either a normal fashion, a not so normal fashion, so they can't really do it very well, or even a hyper-metabolic fashion. Something like Plavix, which is a blood-thinning medicine, if you get that and you hypermetabolize it, you can get the toxic levels and then bleed. And so what we're hoping to do is to personalize pain management in orthopedic surgery. Patients that will be given, when they are signed up for surgery, they will be evaluated by a nurse. There is a validated addiction profile that will be given to the patient. There is a validated, we have a lot of trouble with clots in the legs after surgery, so we call that DVT, a DVT profile. We'll then have an accurate medical reconciliation, so all the drugs they're on will be looked at. And we will then send off both a urine tox screen as well as a genetic sample that can be evaluated at this laboratory, and we will get a scorecard back. And we'll be able to say, your risk of addiction from 0 to 10 is an 8 or 2. Same thing with DVT. Why that matters is that we may be more aggressive in some who have a high risk and some who have a low risk, because if we use aggressive medication, then often they bleed. And then we can change the medicine as we see fit. So we're going to begin this, we hope, in the next several months, and we hope to get back to you with some data over the next 12 to 24 months. Excellent question.
Okay, thanks, Dr. Kelly. So another question that just came in, and I know you have a lot of experience in this area, as we discussed a multitude of times. If there's an individual that has a history of substance abuse, do you believe that there is any safe opioid that can be prescribed to these people?
You know, I'm not necessarily sure I'm the right person to give you the answer on that. I don't know that any opioid is safe in this particular group, but I'm not a substance abuse expert in this area. I know that when we have people like this who are having trouble, we are very, very tuned in to getting the people such as our pain management people who deal with this chronicity of substance use over and over every day involved and work together with them. I think they try to stay away from the opioids, but if they're clean, I don't know the answer to that, and I suspect it's one of great trepidation would be my answer. I don't know the accurate answer on that. I think you have to be very careful, but you should have, if you have people that know more than you, then I would get them involved.
So from what I'm understanding from your statement is, you might a referral to chronic use or pain management.
I would have a conversation with the patient. I would, some of these people they are more scared than we are. If they've been sober now for a number of years and they went through that battle, particularly if it was an opioid or heroin battle, which I think is really, really difficult, then these people are scared of the pills themselves. Now, if they're coming in and looking for those pills, then they're not. It's not a history. It is a use, in my mind, because these are the people I think are most paranoid about, and even alcoholics, same type of thing. Many of them are very nervous. I have family members who have this, and one just recently broke 3 ribs in a bicycle accident. Been sober now for 8 years, and he was very, very nervous about. There is pain. It needs to be managed, and he did have opioids for a short period of time, but was on round-the-clock anti-inflammatories and Tylenol and opioid rescue. So I think, again, that's as good as I can do on that one.
Do you think that in this group there would be a good place for the human genomic testing as well, if it hadn't been done before?
I don't think it could hurt. I don't think it could hurt.
So it really leads into our next question, which was submitted by Shelley, and I'll make a statement and then pass it to you. And Shelley's question was, well, how can patients locate physicians who use a multimodal technique? So, Shelley, to the best of my ability, I don't know that everybody advertises or during, you come in to see the surgeon, that they even have the ability to go into a true what is multimodal technique. I know if you get on the www.planagainstpain, there's all the questions that empowers you as a parent or a patient to ask the right questions to be able to, speak to the surgeon or the healthcare practitioner about, are they using multimodal technique? How do they feel about opioid minimization? So Dr. Kelly, what's changed in your practice that has enabled you in response to Shelley's question overall to really implement this multimodal technique in opioid minimization? Have you just done it? Have there been other people you brought along with you? Has it been?
I think in orthopedics that we were very early to this game a little bit. Some papers came out of the Hospital for Special Surgery, and later we actually got into this with peripheral nerve blocks to start with rather than the medications. And then gradually we got involved in the medications probably between 2008 and 10. And then we became more aware of the opioid problem. And then we kind of, I think there was some good papers came out. And I would think, at least in orthopedic joint replacement surgery, which is what I do, that you won't see a lot of that advertised right now. You may start beginning it as this is a problem that is worthy of marketing from time to time. But I think where you'll see it hasn't changed my practice. I talk more about the different way we're managing pain now than 6 years ago when we started this than I do about how I do the procedure. And we also, one of the things you'll find that we think is huge in helping line up both surgeon and patient expectations is we have a very, very significant patient education program. And pain management is, one of the parts of this is that in the past we had questions in the hospital known as HCAPs. And these were trying to gauge the patient's satisfaction in a variety of ways. How noisy was the hospital at night, et cetera. And one of these is how well was your pain managed. And so that led to, I think, of some increased use of opioids because patients were saying, I still had pain. But now we educate them. You're going to have pain, but we're trying to give you manageable pain without adverse drug events. We bring our patients out of bed day zero now, where in the past they were throwing up or they were nauseous. I mean, it was very problematic. And getting away from IV opioids, our nurses and our therapists absolutely adore this whole patient population now. So I think you will see it in orthopedics, but I would agree with Harry. I would refer you to the website. Educate yourself more. You've had a little dose of it here today, and you'll be able to, any surgeon that doesn't respond to your questions, then you need to move on.
Okay, I think maybe Mike want time for one more quick chat. So a lot of patients that, may be addicts or have an addiction to A, B, C, or D, or in recovery are in fear of being judged, right? They don't really want to have that conversation. Can you tell me, has that happened with you, and maybe what is a good way for healthcare practitioners in general to handle that?
Well, I'll tell you my example is that one of the only patients I've ever had to revise their total knee within 6 months of surgery was such a patient. He had been on huge doses of opioids from another institution, another physician, and did not share that with me. And post-operatively, we could not manage his pain. He was hyperesthetic. This is a retrospectoscope, and I didn't see it at the time. And when you don't straighten your knee after surgery and it goes 6, 8, 10 weeks, it will never straighten, and that's a terrible way to live. And that's what happened to this gentleman, and I had to revise his knee at 6 months. But the etiology of that was me not being aware of his pain problem and addressing it ahead of time. So I think that it's very important that does. And one of the things we hope this addiction profile, which has been validated, and I don't have enough information about it right now, but if we're and to the point that we heard earlier, if you start doing tox screens and take addiction profiles on a lot of people, you may be surprised with the results you get. But that's one way I think we're trying to address it.
Okay, so I want to, I think here in an effort to close up, I want to thank Dr. Kelly for his time today and I'm going to...
I just have one closing word here, and to
Sure.
people who are here today, and I thank you for your time and your attention. I hope this has been valuable to you. As we close, recovering people need to be totally honest with their doctors and the anesthesiologists. It's a teamwork approach, and we hope this personalized approach will make that even a better experience for such people and to be more comfortable as we do this. We use a team approach to address your concerns about prior drug use. We make no things here other than to even do a better job, because this kind of problem is affecting many of us today, more than people think. So thank you very, very much for your time.
So thanks, Dr. Kelly. Great way to close. Thank you all for joining the webinar, Alternatives to Opioids, and I'm going to pass the ball back to Patty.
Great. Thank you very much, Dr. Kovelman, and thank you, Dr. Kelly. This has been a fantastic, very informative presentation. I've seen lots of great comments from our viewers and a lively chat in the chat box. So I'm glad that to see that happening, and I'm really glad that Faces and Voices of Recovery has been able to bring you this presentation today. Our focus is on removing the barriers to recovery, and we will continue to support the recovery community and what people in recovery should expect in the surgery and how to ask those questions. So this is part of our recovery education series. And Dr. Kelly also touched on some of the public policy issues like the Comprehensive Addiction and Recovery Act. And these are just some of the many things that we at Faces and Voices of Recovery are doing to support you in your work in the recovery community. So thank you all for attending today. And we'll see you again maybe next month on Thursday's webinar series. As we close, you'll see a survey pop up on your next window. So please take a minute to fill out the feedback survey and enjoy your afternoon. Thank you, everyone.